everyone. We're about to begin the fourth and final press conference of this meeting. There have been daily press conferences that have been very interesting. I'm Richard Gralla. I'm a medical oncologist, and I'm co-chair of the Communications Committee for the IASLC, and it's my privilege to chair today's session. We will have brief presentations on these important abstracts and then take questions, and we'll do one at a time with one minor exception to that. These abstracts are considered to be very important submissions of studies that can change the way that oncologists do their practice immediately. And these are things that can change the way we diagnose patients, treat complications, and treat cancer. And so of the many thousand abstracts that were submitted, these are the four that are felt that could have the biggest impact in a very short period of time and give us new information. We will deal with, first of all, a chemotherapeutic agent, a new chemotherapeutic agent in small cell lung cancer. We'll then talk about one of the most common complications of cancer, lung cancer and others, and treating that complication more effectively than we've been able to do before. And then we will look at two papers that deal with modern ways of staging patients with non-small cell lung cancer. And as you know, the staging of the cancer is so important to determine treatment. In 1 minute, I'm going to call upon Dr. van Paul from Germany to talk with us about a new agent in small cell lung cancer. As you know, if you want to sit there or you want to come up here, it's fine. Come on, Joachim. As you know, about 15% of all lung cancer is small cell lung cancer. Lung cancer is so common that 15% of patients worldwide with lung cancer is a huge number of patients. And unlike non-small cell lung cancer, where some of the newest and most interesting findings in non-small cell have dealt with targeted agents, molecularly targeted agents, in small cell lung cancer, the treatment with chemotherapy is more effective, and there are not so many targeted agents that have promise in small cell. So having a new agent that can replace or improve upon the commonly used second-line agent is a real advance in the treatment of this disease. So I'd like to ask Dr. Joachim van Paul to tell us about his very interesting and large study.
Thank you, Dr. Gralla. I present shortly the data of our randomized phase 3 trial of amrubicin versus topotecan as second-line treatment for small cell lung cancer. Dr. Gralla said something about the background. Small cell lung cancer is a typical smoking-related cancer that compromises approximately 15% of all lung cancer in the Western world. While small cell lung cancer is responsive to initial chemotherapy, patients relapse or progressive rapidly. Once patients progress following initial therapy, the median survival time is around 6 months. Amrubicin is a third-line generation anthracycline and a potent topoisomerase 2 inhibitor approved in Japan for the treatment of small cell lung cancer and non-small lung cancer. In phase 2 trials, amrubicin showed promising activity in second-line treatment of small cell lung cancer and in particular in patients who did not respond to their first-line therapy or who progressed within 90 days of completing first-line therapy. That's the so-called refractory small cell lung cancer. Here is a trial. The eligibility criteria were small cell lung cancer sensitive or refractory, and one and only one prior platinum-based chemotherapy patient got. The randomization was in a 2-to-1 way, and the patients got amrubicin 40 milligrams per square meter over 3 days and topotecan in the usual dose with 1.5 milligram per square meter over 5 days, 3 weekly. The survival data from all patients, 637, did not show a real difference. But if we go in the subgroups, we can see a difference, especially in the refractory patients. That's a problem in treating small cell lung cancer, are the refractory patients. Here we have a real substantial value. We have a 6.2 months versus 5.8 months. And what you can see in the curves, like in the upper curve, in the intent to treat, that we have in the yellow one, the amrubicin arm, has a much more long-term survivors as the topotecan people. Here in the refractory patients, you can see the same. We have a significant median overall survival, and then we have a big part of long-term survivors. The sensitive patients are equal. All secondary endpoints showed a statistically significant improvement in the amrubicin arm. The response rate was improved from 17 to 31 with amrubicin. Duration of response was doubled, translating into a benefit in long-term survival, as I showed you. The lung cancer symptoms and the quality of life were significantly improved with amrubicin. You see, in the upper scale, you see the symptoms worsening, and the white columns are topotecan. And you can see in the first column that it's a total tumor burden, what the patient's reporting over 6 cycles or 5 cycles. And you can see a clear improvement in the green amrubicin against a worsening for topotecan, and the same for all the other things like appetite, cough, and shortening of breath. As I have published when I compared topotecan with CARF, palliation of disease-related symptoms is an important objective of therapy, as small cell lung cancer patients who fail first-line therapy generally are not curable. And that is what helped to get topotecan approved. In this study, we demonstrate that amrubicin leads to better symptom palliation than topotecan, and that's for me the most important thing. The conclusion's primary endpoint of survival was not statistically significant different. All secondary endpoints favored amrubicin: the response rate, duration of response, progression-free survival, improved symptom control, and quality of life. An improvement in survival in refractory patients was observed. The safety profile of amrubicin is acceptable. Increased infection mitigated by the use of growth factors, fewer blood transfusions. Amrubicin provides improved tumor and symptom control over topotecan. Thank you.
Thank you, Dr. Van Paul. Questions for Dr. Van Paul? You didn't talk right now too much about the safety profile. In the abstract, it appeared to me that it was a bit of an easier drug to use than topotecan.
That's right.
Okay, and with a few fewer side effects.
Fewer side effects.
Okay. How about the fact that this is given, as I recall, once every 3 weeks as opposed to the 5 days in a row of the topo?
Amrubicin is given over 3 days.
Over 3 days. So
3
3 days versus 5.
Yes.
Yeah.
Mm-hmm.
Okay, and so that's perhaps a slight convenience benefit in that regard. Okay, and any other questions, further questions for Dr. Van Paul? Please come to the microphone. Thanks.
Could you just repeat the median survival data? I did not get it in the relevant subgroup.
In the sensitive, it was 9.3 months. The median survival, and in the refractory was for the amrubicin 6.2 versus 5.8.
Thank you.
And the median survival for all patients was 7.3 months. That's better than with our old topotecan or CARF studies regarding to the third-line therapies.
Dr. Van Paul has published previously both one of the key papers for topotecan to be available, and much of his work has helped us a lot in our thinking on small cell lung cancer, especially in second line. I agree with you that the improved symptom control, and you used the validated LCSS symptom scale issue, is perhaps the most important thing here. A somewhat easier regimen to use than the older one, associated with more symptom relief. We are glad to see a trend towards improved survival, but having symptom control is perhaps, in this group of patients, is, as Dr. Van Paul told us, perhaps a really major goal. Thank you very much, Dr. Van Paul.